Okay? Okay. So, in my 50 years in healthcare, we've had fantastic progress. Hip replacement, dialysis, transplantation, chemotherapy, completely unbelievable. It's been a second revolution. The first revolution was the public health revolution of the 19th century. But at the end of 50 years of progress, every society on Earth faces three big problems. The first is unwarranted variation. And that's variation that cannot be explained by variation in need or variation in choice. So here's a simple example here. This is the rate of CT. About a 10-fold difference. What's right? I don't know what's right. But everything we look at, we see huge differences. The percentage of people dying at home ranges from 45% to 75%. What's right? I don't know. It might be different in Birmingham or Manchester, but nobody seems to know. So unwanted variation. And unwarranted variation, that's variation that cannot be explained, shows two other problems. And the first of these is the underuse of high-value healthcare. So here's a simple example. If we manage atrial fibrillation as well as they do in Bradford, there'd be 5,000 fewer strokes and about 10% less vascular dementia. No more money, no more technology, just there's underuse of high-value healthcare. And that's sometimes complicated by inequity, unfairness. And this is a study from Oxford showing that people from poor populations get less hip and knee replacement than people from wealthy populations. This is the NHS. This is not the private sector. Unfairness, inequity. The second problem that we see revealed by variation is overuse. Overuse of healthcare. Now, this is the most important picture in healthcare. First drawn by a man called Dr. Abadian in 1980. And what Dr. Abadian said is, as you put more money into healthcare, the benefits increase and then they flatten off. So 10-year cervical smear, once a lifetime cervical smear, 10-year interval, 5-year interval, 3-year interval, 1-year interval. One intensive care bed per million population, 10, 20, 30. The trouble with healthcare is the more healthcare we do, the more harm we do. The more healthcare we do, the more harm we do. Now, quality improvement is very important because if you improve quality, this line comes down and that line goes up, but the shape stays the same. In the best of hands, we're doing difficult things to people. We're giving them radiation and chemicals and operations. So all healthcare does harm as well. And what he said was, there reaches a point where as you put more resources in, subtract the benefit, the harm from the benefits, and it starts to go down. Overuse of healthcare. Now, what I want you to do, just to warm up for the day, is to turn to your neighbour and for 90 seconds, just discuss where do you think we've gone beyond the point of optimality. Antibiotic prescribing is one, so you can't have that one, okay? So just turn to your neighbour and talk about either your own service or things you can see happening in the hospital or general practice. Where have we gone beyond the point of optimality? Okay, start now. Ten seconds to go. Time to stop talking. Medical director, time to stop talking. When you're doing stand-up, you're always picking someone in the room. Some important person. So I don't know. Okay, so let me tell you what comes up in town halls and hospitals, and then see if you have anything to add. So, prescribing. Prescribing for old people. Polypharmacy, so, that's one. Joint replacement, hip replacement, knee replacement. The wonderful operation of the 20th century, but are we now doing it too soon to people? Are the numbers are keep going up. Imaging, CT scanning and X-ray are going up to 10% a year. All of high quality, but what's the value of that? What's the value of the last 10% of increase in imaging? And you see here, quality is different from value. We'll come back to discuss this. Low quality care is low value, but high quality care need not be high value. Lab tests, 8% a year. And then we get into some interesting and difficult things like the 8th or 9th round of chemotherapy. Now, I'm not saying that no one should have an 8th or 9th round of chemotherapy, but did they really know what the choice was? And the side effects and the benefits? And this brings up the big issue, and it comes up in public, is care in the last year of life. You know, are we doing too much for some people in the last year? Nothing to do with the money. This is not to do with the money. And it ties into the fact that in some places 75% of people die in hospital, and other places 45%. Because when you're admitted to hospital, then things start to happen to you. And they may be high quality, but these are things that happen. I reckon we spend £1 billion in the last year of life doing more harm than good. All by well-intentioned people trying to do the right thing. But I'm sure you've seen this with family or friends or whatever. People just get into the system and then things happen to them. Any other things people came up with? I'm sure there's lots. Well, yes, at the back, shout out.
I think in child psychiatry we are also seeing the similar kind of thing where behavioral problems are being increasingly medicalized.
Yeah.
And family issues are being medicalized.
Yes.
So we get a lot of people that way. I don't know the number, I can't give you the numbers actually, but I think it's a major issue.
Yeah, I think things happen, particularly, I think this is one of the most difficult areas that we get epidemics, ADHD. I mean, there's no doubt that ADHD exists, but then other people start coming up and put pressure on you to prescribe because they've read about it. Yes, other issues anyone would like to bring up? Yes, over here. Just shout out.
Repeated assessments, over-assessments.
Yeah. Seeing people again and again and again. We'll come back to that. Yes?
Referral for actual social problems rather than medical problems, or assuming they're medical problems when they're actually social.
Yeah, Ben, saying in one of the projects, I work for something called NHS Right Care, which is a bit more in commissioning. And up in Blackpool, the ambulance service employed a really, really nice person to phone up all the frequent flyers and said, look, you're obviously worried about things. Can I come in and have a chat to you? And, you know, the calls to the ambulance service went down because we were sending out 111 when what they wanted was something quite different. Yep, at the back table, shout out.
Not being able to discharge patients because they're homeless.
Yes, homelessness. The fact that we are having to cope with homelessness, and we've been doing projects on single homeless people. Okay, so there's overuse. Now, we need to think what we're going to do for the future. Need and demand will go up 20% in the next 10 years. You guys are the leadership of 2027, 2037, maybe 2047 some of you as the retirement age drifts away from you. So you're the guys. We need to think about the future. The future, you see, is not like, it's not like the North Pole, a destination. The future is a bit more like the Forth Bridge, something we imagine, design and build. So we need to think now, and you need to think, that's the purpose of these meetings you're having here, about designing the future. So we've done 4 things in the last 20 years, and all of these are very important. So we've done prevention, evidence-based decision-making, quality improvement, and cost reduction. All of those are very important. That's the Fab 4, and they must continue. But at the end of 20 years of doing this, we've got unwanted variation, underuse, and overuse. So these are necessary but not sufficient. So we've got a new agenda now, and this is the new word. You people who are running the health service in 2027 and 2037, the word is value. Now, value is a very tricky word. The word value in the plural means principles. The hospital's values are excellence and compassion, for example. But the word value in the singular has more of an economic meaning. So now I want you to turn to your neighbor and say, what is the word? If I say the word value is the most important word for the next 20 years, what does the word value in healthcare mean? Okay? Work with your neighbor now. So let's hear from some of the tables as to what came up. You guys here?
Yeah. I think when you're talking about value, to my mind, it's about the person. It's the person's value.
Person's value. Okay, good. We'll take that. That's very good. So there's an individual value, yes? This table here? Yes, you've been volunteered.
I felt values, a lot of people think spend more money. It's not about the money. It's about our own perceptions, how we treat people, and how we uphold the values of the trust.
Yeah, it's our own perceptions. You see, value is subjective. Quality is objective. Number of hips that need to be replaced in 3 years, or number of people who are admitted or show unit. That's an objective measure, but value is very subjective. Very subjective. Yes, this table here?
We were talking about cost effectiveness really, and if something is doing a really good job but not actually costing you very much, and then we gave the example of something that wouldn't be, like somebody spending a night in a hospital bed and how much that costs,
yes,
which could actually be achieving very little.
Yep, good, good. So it's cost effectiveness is part of it, yes? Yes?
So aside from it being kind of like the financial benefit, also is something worthwhile doing compared to something else?
Yep.
Yeah, the value of one intervention
Good.
over another.
Okay, so here's another interesting thing here. It's to do with compared with something else. So there's a value of a thing in itself, but you're also thinking of something else. Anything else you'd like to comment?
Yeah, we were just discussing amongst ourselves, in a consumer market, it's always quality versus cost and whatnot. So
yes.
It's measuring the two.
Measuring the two, yeah. Quality, I'm not so happy with quality. What I want to measure? What I want to measure, not quality. Begins with the O. Outcome, yeah. So the quality may be good, but you don't. So the quality of all that imaging is terrific. These guys are, European standards, ISO. So the quality is absolutely tip top. But what's the outcome? What's the outcome that we're getting? Okay, well, you've done very well, I can tell you that, compared to many other groups I deal with. And this is what we call triple value. So triple value is first personalized, you mentioned the person. So it's very important what happens to you, outcome. And then there's two aspects of value related to the population of Northamptonshire. One is allocative, so measured by what else you could do. And the other is technical. Now, the value it's a bit more than efficiency for reasons I'll explain. And then the opposite of value is waste. Waste. Waste is anything that does not add value. So this day is a waste if it doesn't add value to the people of Northamptonshire. I remember I was thinking as I was coming up here, I used to go out a lot in Oxfordshire, Northamptonshire, speaking at Old People's Club. And they said, we'd like to thank Dr. Gray for his very valuable time. I said, my time's very expensive, but I haven't even spoken yet, so you can't say it's valuable. There's no value to it. So waste is anything that does not add value. This is very Japanese. It's very Toyota. I see you've got a Henry Ford dog in an academy up the road. What's that?
Yeah, it's a training centre.
For who?
For apprentices.
It's interesting, yeah. So I've been very influenced by the motor industry. And Toyota, the word muda is waste. They hate it. Muda is waste. There's another wonderful Japanese word, multinie, which is a feeling of remorse for having wasted resources. Oh, I shouldn't have ordered that MRI. Oh, no. I don't see much of that in the John Radcliffe, I can tell you. So waste is the opposite of value. And then the Academy of Medical Royal Colleges produced a very good report about value, and they talked about a culture of stewardship. Stewardship. Stewardship is quite a difficult word. It means to hold something in trust for another. If we screw up the NHS, it won't be there for future generations. We're the stewards, like we're the stewards of the planet. It's like environmental. We have to just look after it for future generations. So let's just look at these in more detail. Now, in the jargon, this is what's happened in the last 50 years. So we need to think of effectiveness. Does it work? Evidence-based decision-making. Cost effectiveness was mentioned here. Then we've had quality, and now it's the value. The value. This is what's a paradigm shift in the jargon. But value is the key issue for you in the next 20 years. Different types of value. Okay, let's just get the jargon clear. Productivity is inputs over outputs. That's an economist term. So duration of stay for hip replacement, for example, or percentage of drugs that are generic. Productivity. Not outcomes, just outputs. Then we come to efficiency. Now, efficiency is the percentage of people who have a good outcome related to the cost. And what we're starting to do now is to say, we don't just want to know that they got out of the hospital, the hip replacement, but did it make a difference to their life? As a friend of mine said, he came and said, could I come and see him and his wife about a knee replacement? He'd been told they needed a knee replacement. So I went to see them, and his wife Trish was sitting beside him. I said, well, Albert, what's the problem with your knee? What's the problem? He said, oh, I walk very slowly now, and Trish, his wife, she complains when we're out. I said, well, change your wife. She liked that very much. And then I said, what about pain? He said, I don't have any pain. I said, you don't have any pain? What did the surgeon say? The surgeon said, well, you should have pain with an x-ray like that. This isn't a health economy, it's 20 million in the red. Nothing to do with money, it wasn't private practice or anything. Just a keenness to operate. So we're now starting to ask people a key question, what is really bothering you? And I think, and actually a friend of mine who used to run the child guidance service in Oxfordshire, long before the internet, would write to families, maybe you do this here, what is really bothering you, and what do you hope we can do about what's really bothering you? Another person came in to see Andy Price about, she said, I need a knee replacement. He said, well, what's bothering you? She said, I love gardening and I can't kneel anymore. I've had difficulty bending. And he said, well, do you realize if I replace your knee, you might not be able to kneel at all? And she said, thank you very much, Professor Price, and walked out. Now, whether she went for long-handled gardening tools or raised beds or something, but replacing that woman's knee would have done nothing to what was really bothering her. So we're now moving from the diagnosis to what's really bothering people. And that's less of a move for you than for the hospital sector, but it is something that we should be doing much more, and getting people to think, and I'm sure the mental health service does this, before people rock up, they've got to bloody well think, what is really bothering them? Otherwise, you spend the first 10 minutes of the consultation, toing and froing, which could be clarified by people being asked, our clients, our patients, being asked to think before they come. And then the value is much more than efficiency, because we need to think about, are there people in Northamptonshire who are not getting the service who would benefit? And that means there are other people getting it who would benefit less than the people who are not getting it. And the resources here is not just money, as someone said. There's also environment, and I've been very much involved in sustainable healthcare, low-carbon healthcare. And the carbon footprint, hospitals have a carbon footprint. I don't think you've got a carbon footprint. The hospitals now have to have a carbon budget. And I find many people like you are more interested in the carbon than in the money. Because your children are interested in the carbon and the climate change. And of the carbon, only 20% is heating and lighting. 20% is staff and patient travel, and 60% is drugs and equipment, the carbon that's gone into the making of the drugs and equipment. And then there's social resources. Could we do more for the population of Daventry by developing the allotments or encouraging, even paying for clubs of older people to meet for exercise classes, getting social involvement. And then this issue of time, which we've always, now your time we're very worried about, but the time of patients and carers we've not worried about. And for example, I've just come up from Oxford this morning, and supposing your mother lived in Whitney and you lived in Bicester, and we gave your mother a 9 o'clock appointment at the John Radcliffe, what time would you have to pick your mother up? When? 6. You'd probably get away with 6:45. But remember, the letter now from John Radcliffe says, please allow an hour to find a parking space when you get here. Is it the same for Northampton General? Yeah. 15 minutes. Pardon? 15 minutes. Yeah. And then when you bring your mum in, we say, oh, terribly sorry, we forgot to organise the MRI. Just bring her again next week, would you? So time. It's a woman called Frances Mayer, a Professor of General Practice in Glasgow, calls it the burden of treatment. The burden of treatment. Not the burden of disease, but the burden of treatment. And it's a very good concept. Okay, so let's look now at remember, you have to carry on with the Fab 4. Prevention, evidence-based decision-making, quality improvement, and cost reduction. But here's the 3 new things that you need to do in the next 20 years. Number 1, let's get the resources right. Now, this is partly the job of what's currently called the CCG. The jargon now is an accountable care system. Do you know where we are with accountable care systems? Has anyone mentioned them here? Alex in Northamptonshire? It's just... Pardon?
Early stage.
Yeah. I mean, it's a very, very radical idea. You just bring everyone together in the one room and you say, boys and girls, let's get together now and not play games with one another. And so that's what's called an accountable care system. So bringing people together. Because in 1987, Kenneth Clark split up Northamptonshire Health Authority and created the internal market. And I mean, the hospitals are way over there, the GPs are over here, and the mental health trust is over there. And the hospitals are meant to compete with one another, so don't speak. Northampton couldn't speak to Kettering, oh no, you mustn't do that, you know. So it's been, in my view, had very serious effects, and we now need to get together. So starting to get together. And this is what the CCGs do at the moment. So here's the sort of spend on in England. Oh, it's like a cake. How much do we spend on mental health compared to, this is millions of pounds per million population. How much do we spend on mental health? Any guesses? Sorry? 30? It may not be enough, but it's more than most people think. More than most people think. But actually what we find is the CCGs have never actually looked at their accounts properly. And often the CCGs, any CCG people here? No. I mean, I was at one of my interests, but my main sort of interest, as Alex said, is healthy aging. And also where aging and long-term conditions overlap. I write very academic books with names like SOD 70 and SOD 60 and Sod It Get Moving for your mum and dad. So SOD 70. There's 4 things happening to us. Aging, not a big problem till your 90s. Loss of fitness, which happens for most people from about 20 on because they get a sitting job. Disease, much of it preventable. But then disease and loss of fitness overlap. Because when you get a long-term condition, people start doing things for you. Oh, Mum, don't go for the shopping. We'll get Ocado. They'll do a delivery. Well, Mum, you really need to go shopping. You know, it's called training. I don't like the word care, by the way. I don't like the word care. It means, well, I'll do things for you. It doesn't need to be caring at all. And then the 4th thing. So that's aging, disease, loss of fitness, and attitudes and beliefs. So starting to think in different ways how we do things. But at the moment, this is the way we've got things grouped. And of course, many people have got more than one condition. And this used to be called multimorbidity, but I think it's multi-specialty is the problem. You know, the person goes to see, and this may happen to some of your parents actually, you know, they go and see one specialist who prescribes something, and then they go and see another specialist, and they prescribe something else. And the specialists don't even know about the interaction between the drugs. So how does the community nurse and the GP, do you have, what pharmacy service do you have, Alex?
We have with Lloyd's.
Yeah. So we're needing now to think much more about how we get pharmacists involved in sorting out this polypharmacy problem. So complexity is an 85-year-old woman with 5 diagnoses, 12 prescriptions, looked after by a 50-year-old daughter with an alcoholic husband. Pretty standard for you guys in general practice. You're very good at complexity. The community nursing service is very good at dealing with complex cases. But when one of the disorders becomes complicated, then you need to refer. Now, the next stage in allocation, and I've picked a medical example, our hospital example here, is how do we allocate the resources? So in the mental health service, I'm pointing at the table back there, I know there's other people, but in the mental health service, how have you decided to allocate resources for children, old people, alcohol and drugs? These are very difficult decisions, but it's called allocative value. How do you allocate? And have we allocated optimally? And I can tell you that if you look at most things I look at, for example, something quite simple, like musculoskeletal disease, there's a 1.8-fold difference in the amount allocated in one CCG or another. I mean, that'd be equivalent to about 20 million up or down in Northamptonshire. And the CCGs have never really looked at it. I mean, yesterday I was thinking about the meeting we had on deafness, and this CCG up in the north is wanting to cut hearing aid spend. Well, why the hell is a CCG getting involved in the detail of hearing aids? You know, their job is to do this sort of stuff. But in some way, it's much easier to get involved in cutting something or, you know, making savings for this tiny service called the hearing aid service, instead of switching money from polypharmacy into hearing aids. Because almost certainly in that population, there's £2 or £3 million worth of prescribing, probably doing no good and maybe doing more harm than good. So they need to think about allocation, allocated value. Okay. The next thing is to develop systems. So we want to allocate. I've kept the personalized value. That was the number one. I'll come back to personalized value. So we want to allocate the resources properly, and that's part of the CCG, but it's also you. How do you allocate resources within your trust to different subgroups of the population? And then once the resources are allocated to systems, and this is what we call population healthcare. And population healthcare is healthcare organized not by primary or secondary or tertiary, but really, really focused on the subgroups of the population. People with atrial fibrillation, people in the last year of life. And once you've got, so let's take something quite simple. I've been working on atrial fibrillation. And once you've got a system for atrial fibrillation, then you start to say, well, is the specialist service, and this is a classic for mental health, of course, is the specialist service seeing the people who'd benefit most? Because if they're not, it's a waste for the service and for the individual. So starting to think, if we give you people responsibility for the population much more clearly, then we'd make sure we would see the people who need to be seen, but also the ones who weren't being seen would get some sort of service and support. And this is classically a problem for the hospital service, and I often ask the hospital chief exec, are you in the real estate business or the knowledge business? Because you've got all these clever people, dermatologists and the like, but the only way to see them is to find a parking space and go and see them. Because we pay you to keep the real estate going. So we're now thinking of ways in which we would pay the specialists and we'd pay people like you to start thinking about the whole population. Leg ulcer would be another classic example of this. Leg ulcer is one of my interests in terms of a huge problem. It's probably £500 million a year is spent on leg ulcer. And we don't know what's happening. And we don't have a clear sense of direction. And this would also allow us to fund innovation. But we haven't got any more money, so we have to fund innovation by finding things of lower value and stopping them and starting things. So we want you all to do more, but do more high-value things, and we'll find the money from lower-value things to fund it. And then this is the final bit about a system of care, and it very much involves you. Have we got the balance right along the care pathway? And this is work we did in London on bronchitis. And we got all the people in the room, respiratory physicians, nurses, scientists, patients, very important are the patients in. And we say, ladies and gentlemen, for the next hour, don't campaign for more money for COPD. How well are we using the money at present? And what we decided there was let's switch money from triple drug therapy to smoking cessation and rehabilitation. 3 different budgets, but actually director of finance say, yeah, we can do that. Any finance people in the room? Yeah, finance people are very important to have in the room. They can do these things. The dark arts of finance. So I always have the finance people in the room. Yeah, we can do that, yeah. It might take a year or two, but yeah, we'll go away and do that. So starting to think of how we might use resources in that way. And then finally, we need to ensure that every individual receives high personal value. And this is the way we thought about decision-making when we set up the Centre for Evidence-Based Medicine in Oxford. So there are 3 aspects to a decision. First is the evidence derived from the study of groups of patients. Secondly, there's this patient. And this patient is often not anything like the patients in the randomized controlled trials. They're often a randomized trial of people who only have type 2 diabetes, but how many people only have type 2 diabetes? You know, there are lots of other things. And then there's the values that this patient places on the benefits and harms, the values of the individual, like my friend with a knee replacement. He eventually had a knee replacement, and he said pain ever since. And he's wondering just why he had it. So the values, what's the trade-off that individuals have to take? Now, just to finish, this is starting to think about the third revolution in healthcare. So the first revolution was the public health revolution. And that was quite simple in that it was an environmental revolution. But to solve the problem, you needed a bit of knowledge. John Snow and the Broad Street pump in Soho, he took the pump handle off, and then people saw it was the polluted water was the problem. You had to have politics. You had to have the government was getting strong at that time. You know, it wasn't as corrupt as it had been in the early 19th century. So it was an environmental problem. Actually, my own view is we're now in another environmental problem, and the problem's created not by polluted water, but by the car, the desk job, and the internet, inactivity. So no point just telling people to become more active, walk 10,000 steps a day. It's a waste of time. And one of my ambitions, not yet achieved, is to get Bear Grylls to do a program. See, Bear Grylls leads a very healthy lifestyle, running about the countryside eating berries. He's low risk. That's Paleolithic man in the Paleolithic environment. I want Bear Grylls to commute from Vauxhall to Barking and sit 9 hours at a computer. Then I'll bloody well see how he's getting on with his... So it's an environmental problem. And one thing I'd like you all to do is to download the app www.nhs.uk/1U, O-N-E-Y-O-U. Have any of you got the Active 10 app? It checks if you're walking briskly. And I want you all to do 10 minutes brisk walking at lunchtime, okay? So it's an environmental problem. Then with the second revolution, that was high tech, epitomized in many ways through the hospitals. And I often think, if you look, when you're in a city, in any country, the great building for many hundreds of years was the cathedral in Milan or London or wherever. Then in the 19th century, what was the most important building in the 19th century? The big buildings of the 19th century? Sorry? Yeah, but they weren't glamorous. Big. No, town halls, I always outclip the railway station. The railway station. That was the power. That was the power. St. Pancras Station. Like that. But in the 20th century, the most impressive building was the hospital. And if you walk along the Euston Road from St. Pancras to UCLH, it's like a cathedral, isn't it, UCLH? Shining. Come here and be healed. But we're now in the third revolution. We certainly need hospitals like UCLH and Northampton General. But the third, this is the map of the cholera map here, the second revolution. But the third revolution is driven by three forces: citizens, knowledge, and this. This is more disruptive than the human genome. And we're probably 10 years off the pace in using it. I had a health checkup recently. I had a heart attack a few years ago. And they sent me nothing. They sent me nothing. And then when I asked for something, they sent me lab reports. And they think, my practice think I'm Mr. Gray. They don't know what my day job is. No one ever sent me this. No one ever sent me, well, why don't you walk briskly or do anything? I was in the John Radcliffe for a few days. I'm not Alex was quite right. I'm not a fanatic for exercise, but I'm very keen to do 10 minutes exercise every day and 10 minutes brisk walking every day. That's the prescription that we're trying to promote. But I suffer from a very serious underlying medical problem called stupidity. It's a male-linked disorder. And I was running for a train. You should never run, never run. particularly not with reading specs on and a bag in your back. And I tripped and broke 7 ribs. And then I went to London to the meetings. I mean, stupid it is. But I was in the John Radcliffe, and I think they had asked my address 4 times and my email never. So we've got to think, we just got to make the jump. And that would include people in their 80s, with dementia. They should all have a tablet. Otherwise, how does anyone know what's happening to them? Even if they never use it, we should start. So I'm looking for organizations that would like to make the jump to think of this. Only the patient is constant in modern healthcare. They're the only one that's there all the time. So starting to think about, as we move from this, we have a new environmental challenge called inactivity. We need to carry on doing this, high quality, evidence-based, low cost. But the new value agenda has to recognize that we're in a different world. And this is a man called Manuel Castells wrote this. He doesn't write about healthcare. He writes about, well, look at Uber and everything that's happening in almost every business apart from us, where we're still, goodness knows. I haven't managed to find out yet how much. I still work for Oxford University Hospitals. I don't know how much we spend in postage stamps, but it's quite a bit. And I know not everybody's on this, but we need to make the jump to citizens, knowledge, and this. So that's a brief view as the future is the work I'm doing with NHS nationally and with people like you in different parts of the country, where public health and the NHS come together. Because the issue about activity therapy is that we need to do, it's not just to prevent disease, but everyone needs to become more active. So one of my ambition now is to introduce a national activity therapy service, and it'll be as much for the 60s, 70s, 80s, and 90s at home as for young people in gyms. I've tried to give you a picture of the new world. The new language is a language of systems, a language of value. So just to finish, 2 minutes talk to your neighbour for a takeaway message from this that you might be able to apply in your own particular unit, and then it's performance-related coffee. Okay, turn to your neighbour for 2 minutes just to finish off. Okay, let's just take a couple of points. And there's a table at the back, been sitting very nicely, quietly there, so...
I think the 3 takeaways, I think, for us on this table. First one is walk 10 minutes briskly every day. The second one is, I think, really looking at value and looking at, I think I was really, really impressed by the slide of high quality but low value. And I'd really like to have a reference to kind of read that article, Prof. And I think that's what we were talking about, to look at what are we doing, because we are convinced that we are high quality in everything that we do. But I think to look at, is it high value? And I think that may be where we could improve in our trust, yeah.
This table here. Lady with in the middle there, yes. You.
I think we talked about being more creative and thinking about apps as a way forward in addressing healthcare. And really, the big message was to ask people what they really want before we move forward.
Okay, I think you've done very well. Get up, stretch, have a cup of coffee, and download the app, okay?